Assalamu alaikum. So we'll talk about anatomy, and this will be my last talk and last presentation, and after that we'll go on to the live demonstration of cases, and I will show the cases to you and you will make an opinion, and then Gopi and I will go through and see whether your findings correlate with our findings, which we might be wrong, you may be right, but we'll go through and we'll educate each other as we go along. And I hope that my Mac works and we can show you the cases. So talking about the spine, as I said earlier in my discussion, that you need to remember the curvatures of the spine, because the pain, the commonest cause of the pain could be loss of curvature. So you need to know where the lordosis is. So if you look at it, this is a spine, that's the posterior process, that's the anterior part. So in the cervical region you have got lordosis anteriorly, then it curves posteriorly, and you have got lumbar lordosis. So if you lose that, normally cervical pain is secondary to the loss of lordosis, it becomes straight. And then again in the lumbar region you lose the lordosis and it becomes straight. There are a number of factors which are the causative agents for these pain, and it could be numerous causes. We'll go through the anatomy first and the association of these loss of architecture in the anatomy, which could contribute to the cause of the pain. These are the plain film, is coned off view, so you don't expose the rest of the chest and the abdomen. So these are the ribs, and if you look at it, these are the spinous processes in the center. These on the side are the pedicles, and the space between these are this space. These are the sagittal lateral view. This is the body. The important thing is in CT on plain films, when you go through the spine, you need to look at the body size. So you look at the length of the vertebra. The first thing that happens is the end plates. Look at this very pristine end plates, and you lose the contours of these end plates initially. The disc becomes narrowed, and then these two oppose each other and causes destruction. So when you're reporting a CT and when you'll be reporting spect CT of the spine, then you look at the height of the vertebra. So you'll talk about the vertebral height, you'll say loss of height or the height is maintained. Then you talk about the disc, because the disc spaces should be maintained throughout, and as you go down it slightly increases because the lumbar vertebrae are wider and bigger. Then you talk about the loss of height and of the intervertebral disc, and then comes the inferior end plate of the upper vertebra and superior end plate of the lower vertebra. So you talk about the end plate changes. So there's destruction, sclerosis, and cyst formation. These three things go together, and then you see the osteophytosis. Osteophytosis are calcification, which you can see laterally along the lateral margin, and they can form bridging, or you can see anteriorly along there. I'll talk about the ligamentous attachment of the vertebra, because there is a significance of these ligaments. So looking at this is the C1 and this is the C2, which has got the odontoid process which articulates with the first cervical vertebra. This is very important, especially in rheumatoid arthritis. If you're doing a spine, especially, you'll be doing a lot of fluoro. You need to look at this and this is very crucial and important in patients with rheumatoid arthritis, because this is the area where you see destruction, and you need to comment on this, because if this patient goes to surgery and the anesthetic has to anesthetize this patient, he needs to extend the neck. And if there is severe degeneration in this joint and you don't comment, this patient may die on the table, because the moment he extends the spine, it may dislocate and causes stenosis of the upper cervical vertebra, and it causes respiratory arrest. So again, the same principle, you talk about the height. Height is maintained throughout, and how do you measure the height? It is relative to one another. So you compare the heights of the upper and lower, and you compare them. And same for the disc, you basically compare one above or two above and below. So this is the magnified view. These rounded things are the pedicles. If you are just looking at the plain film, you should look at these, and if you don't see these rounded things and there is lucencies, then you will suspect that this may be destroyed and there may be a metastasis or something developing there. So it's nicely shown on this. These are the spinous processes. Again, these are the intervertebral disc and SI joint. So again, so here now you can see between the two vertebra, you've got this intervertebral foramina. Through this, the nerve roots exits. And this is very important because you've got facet joint at the back, you have got ligamentum flavum there. So if you've got arthropathy at the facetal joint, the ligamentum flavum, the muscle here, also hypertrophies and then causes stenosis. And then this can cause radiculopathy distally. So looking at the vertebra, so you've got this spinous process. This is the lamina, and these are the pedicles. This is the spinous process, and this is the facet, and this is the body. The body, you divide it into three parts: the anterior, the mid, and the posterior. You will see when you start reporting spect CT, fractures. That could be osteoporotic fractures, that could be traumatic, and if you're looking at myeloma, there will be multiple fractures. The importance of this fracture is, if it is anterior, it is stable fracture. If it is middle compressions, then they are still stable, but if it is posterior, it becomes unstable fracture, because you've got the cord here. So if there is a fracture going through from here involving the posterior compartment, it may displace posteriorly and cause compression or narrowing or stenosis, and you can have cord transection. So it's very important. So this is very simple. You say anterior compression or middle compression or the posterior compression, or there is complete compression fracture. So again, these are the superior, inferior facet joints. This is costal cartilage coming in, this is the rib. So this is basically thoracic vertebra, and that's the spine. The anatomy of the cervical vertebrae are slightly different. This is C2, this is C1, and basically you have got lateral masses with the lateral transverse processes, anterior arch, posterior arch, and then you've got intervertebral foramina there. So you've got nerve, spinal cord, and the vertebral arteries passing through, and the nerve roots are passing, especially from the C1. The C2 goes through C1 and goes into the brain. Similarly, this is the C2, you've got odontoid, which is very important. It articulates with this and stabilizes the whole cervical spine. So on CT, you look at the disc, which is of this density, is low density, that's the bone white. So disc is there, you see the bone at the margin, so you can, on CT, which is not a good modality to investigate disc, MR is the modality of choice to look at the disc herniation or protrusion. But here you can make a suggestion, and it's just a suggestion, that you can look at the cord and it should be capacious and you should be able to see the fluid. But if this disc prolapse, so you lose that convexity and it becomes flattened or bulged posteriorly. So again, you've got this body of the vertebra. Again, if there is a fracture, you divide it into three. You've got anterior, middle, and posterior. You've got spinous process. These are the facet joints. So you look at the cartilage, the articular surfaces, they're very, very pristine. You've got a space there. The joint is maintained. These are the foramina. So you've got nerve roots coming out from there. It is important because if there is a disc bulge which is going and bulging into and pressing onto these lateral recesses, it can cause radiculopathy. So that's the sac. Thecal sac covers the cord. This is the lamina, and most of the time if you're doing a post-operative spine, you may see transpedicle screws going through the pedicle and into the body. But you need to know that these are the lamina, and if they are doing spinal surgery, they may resect this, laminectomy, and you will see defects. So you need to look very carefully and comment on it. So these are the facet joints. So this is the normal configuration of the joints. If you see loss of space, you comment on it, especially if you are going to do the spect CT. You need to look at it because most of the spines will be degenerative, but you need to comment on them, but you need to say which one is showing metabolic activity and which one is not, because the one which is metabolically active will get treatment, the others, they will not. And if you look at the anatomy, so if you're looking at the spine, you have got other things to look at. So once you have finished the spine, you go back and look at the soft tissue. So you're looking at the kidneys. This is, I think, the IVC probably. That's the aorta. That is probably the vein coming through. Yes. And these are the pedicles. So pedicles, if you see anything, any sclerotic area, they'll be highly suspicious of metastatic disease. So looking at the spine now with the ligaments attached, you have got disc here. These are the anterior longitudinal ligament. These are the posterior longitudinal ligament. These are the ligamentum flavum, which I said is just sitting anterior to the facet joint. It contributes to the pathological changes you see after arthropathy. So they can become thickened along with degeneration and osteophytosis. Together they form a complex mass and causes narrowing of this canal. Through this, the nerve root passes through, exits through, and forms plexus. These are the spinous process. So this is interspinous, and this is supraspinous ligament. When you start doing the PET and the spect, especially on PET, you will see focal uptake here, and sometimes you don't see any degenerative changes. I'll show you, I think Gopi showed one example of this. So you need to be aware that these are not METs, these are nothing sinister, these are just benign. And you just, either you just ignore it or you comment it, otherwise the clinician will ring you and say there is a focal spot in the cervical or in the lumbar spine, and what does it signify? So you can say it is Bastrop ligament, and you don't need to worry about it. So again, the importance of the anterior longitudinal ligament, if you see, it stabilizes the disc. The posterior one attaches to the bone, and with ankspond and ankylosing spondylitis, these are the ligaments which becomes calcified, and you see a bamboo spine. So these are the things which you see the concavity there, these become calcified, these are filled up, so they become square vertebrae, and they are one solid bone. So you need to look at this, and if you see the continuous flow of the calcification, then you suspect ankylosing spondylitis. And then you look at the SI joint, whether there is fusion or there is no fusion, then you are confirmed whether this is angspond or it is secondary to inflammatory colitis. So this is a normal vertebra with the spinal cord and the exit nerve root. So what I was saying, that if you're looking at this disc, if this disc bulges into, that's the dural sac, theca, and the nerve spinal cord is sitting inside. So the first thing, when you get a mild disc protrusion, you indent the theca, and if it is moderate, then you start compressing the spinal cord. These are the lateral recesses. These are the exit nerve root foramina. So if you've got lateral disc herniation, this presses on this nerve roots, and this causes radiculopathy distally. So you can see the configuration of the nerve coming out. So any disc which bulges through will cause compression. So looking at the arthritic hip, what I said is you look at the height. So look at this disc height. So you compare with the normal, which will be, there will be a normal disc somewhere in the spine unless it's completely gone. So you have lost the disc height. The end plates, look at the end plates here. So you have got irregularity, so end plate changes are there. Look at the anterior lipping of these spines, the vertebra. So there is anterior lipping or anterior osteophytosis. The similar appearance will be laterally. If you look at the lateral, so you'll see lateral osteophytosis. Gopi did show you an image where you saw a flow of calcification, and if you have in series 4 at least, then you have got dish. And this is mainly on the right side. Nature has provided it to be on the right side because the left side is the aorta and it's continuous in pulsation. So you don't see calcification on your left side, and it is always on the right side. And dish is always basically corresponds to calcification on the right side. So this is a plain film, what I said about anterior osteophytosis. Look at this is normal disc space, this is abnormal, and this is abnormal, and you've got anterior osteophytosis with end plate changes, and this is still, the disc is maintained, there is loss of disc height, loss of disc height. On CT, again, if you look at it, go up, you start from top, follow the borders, follow the borders, follow the borders, so you've got irregularity, sclerosis, and cystic changes there, anterior lipping, and calcification. So this is a facet joint, relatively normal. This is completely destroyed. So if you do a spect CT, if you see activity, then this could be the pain generator. If you don't see the activity, then it's less likely to be the pain generator. So you need to comment about it. And look at the spine here, the canal here, and look at the canal here. Although you don't see a disc protruding through, but there is so severe destruction, calcification, and ligamentum flavum is also calcified, is causing stenosis. So you can comment, you can suggest, you cannot be absolutely correct, but you can say on CT, which is not the ideal, but it shows, look at the comparison here, and you need to change the window when you are commenting. This is a bone window. If you bring the soft tissue window, then you'll be able to see the disc. There may be a disc here because we are looking at the bone window, you may not be able to see the disc. So if you go on to the soft tissue window, then you will see the disc protruding through along with this facetal arthropathy, which is making a complex and causing narrowing or partial or mild stenosis of the canal. So If you look at the right side, so there is destruction and probably some thickening of the ligamentum flavum, and there is mild, look at this and look at this, so there is mild stenosis of the canal, and this one is relatively normal. So looking at the spine here, and then if you put the, you haven't got the fused images, so basically you can comment, so relatively normal, this one, subtle changes. So here you've got the space, you've lost the space, and here there is destruction of the bone as well. So on CT, anterior osteophytosis. If you see here, it's lateral, and if you see here, that's facetal arthropathy. So now if you change the soft tissue window, you can see the kidneys, you can comment about it, you might be able to see a tumor there sitting, or you see liver, you may see some lesion, you can see a mass, you can see lymph nodes around the aorta. So this is probably at the hilum of the kidney, so that is likely to be T12L1. And this is the celiac axis, or SMA. L1 is SMA. So SMA is superior mesenteric artery coming out. So you can see the lymph nodes, and this is the IVC. So it's just a basic anatomy you need to remember, and need to look. Once you start doing the spect CT, you need to look at it. We'll talk about CT tomorrow, but this, just going through quickly, these low density area, all this black is the fat, air is black, and this is soft tissue, and this is erector spinae muscle, and this is subcutaneous tissue. Again, this is basically what Gopi showed you. So there is this anterior osteophytosis, there's bridging, and now if you look at this, and it's a continuous flow, and if I'm reporting this and there is a cause of pain, then probably I'll say there's flow of calcification anteriorly, and there's this lucency here. So either this is incomplete or it may have fractured. And if you do a spect CT, if you see uptake, then this is most likely the cause of the pain. So it's just basically just going through systematically. Anatomy and radiology basically is systematic approach. If you are very systematic, you will not miss anything. If you are not, then you will lose important findings. Just a distraction will basically make, you can make errors just by a slight distraction. So it's very important when you're reporting, there shouldn't be any disturbance, and you should be reporting without any interference. Gopi showed you this. Basically, you've got a combination, a complete sclerosis of the vertebra, and then you've got spots here, here, here. What is a differential? So you need to look at this as a whole. So what I said, look at the architecture of the morphology of the bone. So you look at this, the height is relatively maintained. Sclerotic though, but the margins are still maintained. So it does not at present look like a destructive lesion. So on the basis of this, I may say maybe it's not metastatic, but I may be wrong. This could be metastatic, this could be metastatic, or it could be a combination. Lymphoma can cause similar appearance. Osteoblastic metastases can, but since if it is so big and the margins and everything is maintained, I would be less inclined. Paget's is a possibility, but again, when we describe this, it is sclerotic though, but it's not expanding, and the chances are less likely. But it's just playing the game which one is most likely and which one is less likely. So you'll throw in a differential, and then you'll say if there are lymph nodes on CT and spleen is enlarged, then this is most likely to represent lymphoma. So it's basically you need to look at the ancillary findings and put them together, and then when you conclude, then you give your differential. Again here, solitary lesion, solitary lesion. The question is bone metastases, and if you have got primary, that is most likely to be a hyperdense lesion. So as I said, when you're describing on CT, you will say the density. CT represent density, Hounsfield unit represent density. So you talk about density, and there will be a measurement. You just put a cursor on that, and it will give you a Hounsfield. And I told you in my early lecture, you have got Hounsfield of from minus, normally 0 to 1,000. 1,000 represents more calcified, and 0 represents air. And if you go into minus, then it becomes fat. So if you put a cursor here, or you put a cursor here, if you've got a solid lesion here, and you want to see whether there is fat, so you just put a cursor, it will tell you it's minus 20, then you are happy, this is a benign fatty lesion. Same with the adrenals. If you're thinking of an adenoma, you will see more often when you start reporting PET-CT that you will see adrenal nodules, and you don't know with mild uptake, and you put a cursor on that. Anything which is less than 10 Hounsfield unit, you are safe, you can say it's an adenoma. Anything between 10 to 20, you are indeterminate, equivocal, and anything above 20, you are absolutely confirmed that this will be metastatic in the presence of primary. So again, looking at this, you look at the whole spine, look at the curvatures. So as I said, lordosis, posterior lordosis, and then convex anteriorly, and then concave posteriorly in the lumbar region. Look at the sternum. This will be the most common site of metastasis if it's a female. Look at the cervical spine, look at the degenerative changes, metastatic lesion, or look at the canal, whether there is anything which is protruding into it causing the pain. So this is disc, degenerative disc. Air within the disc confirms that this is degenerative and is vacuum phenomena. I think Gopi did talk about this pars defect. It's like a Scotty dog. So if you look at this, this represents a Scotty dog with a neck. So if you have got a fracture here, so it's a pars defect. It can be unilateral, it could be bilateral. If it is bilateral, this provides support to the spinal vertebra. So if you've got bilateral pars defect, then there is possible movement anterior and posterior. So you have got listhesis. As I said earlier, that now sometimes before I talk about what happens, I would basically, how will you differentiate? Sometimes it's very difficult when you're looking at the axial slices. So these are the axial slices, these are the sagittal slices, and if you see the anteroposterior, so those are the coronal slices. Axial slices, if you just whisk through, if you are just going through the spine, you may just pass by and you just ignore it because you'll say, oh, this is a facet joint. So normally, facet joint are in line like this. I'll show you probably. So look at this facet joint. So you've got space, and then you've got the joint, and it goes through this pattern. And here, if you see, it's irregular, and it passes through. Most of the time, it is slightly straighter, and it's easier. If you put sagittal, then you see this line. This is not a facet joint. This is a pars defect. So you are seeing from one left to right. So it's sagittal, so you're going from one side to the other. So you need to go through from one side to the other to look at both sides because there are two laminae, and basically you need to go through and see whether there is uni or bilateral. So looking at the spine, when you look at it, Gopi already told you that you measure this is the line. So you just pass your cursor through, and you should pass through each in continuity. So this is fine. Now here, it's not aligned. So you put a line here and a line there and you measure this. Anything which is, so you divide them into 3 parts, and anything which is, or 4 parts. So anything is which is 25, less than 25% is mild, anything which is 50% is moderate, anything above 50% is severe. So you can see the past defect there. Again, so this is about 25%, just about mild. So now in this one, going through this here is fine. Now you see this, so there is injury there, so there is listhesis. Now the description would be, you have got, so you count from here, this is the sacrum, 5, 4, 3, 2, 1. Now the important thing is, I think Gopi did allude to initially that you need to count the spines from here to there, but sometimes when you are counting, you may see that there are 6 lumbar vertebrae. Normally there should be 5. So is it a transitional vertebra? Sometimes you get the sacral vertebra unfused and that represents a transitional vertebra. Sometimes the lumbar vertebra fuses with the sacral and you've got fused transitional vertebra. So it's very important. So the best thing is you count from here and then you look at the 12th rib. So that will be the 12th vertebra and then count again. You need to be absolutely sure because you are going to guide the surgeons where the landmark and the abnormality is. So if we take this as 5, 4, 3, 2, 1, so there is, the 2 is gone anterior. So this one is, here is, this is gone posterior. So this is basically postural listhesis of this one or antral listhesis over this one. And if you look here, both of them are abnormal. So this is normal contour. So this one is gone further anterior. So there is complete disruption of the ligament. So posterior ligament is coming through here. So it's all distorted. The anterior ligaments are here. They are all stretched or maybe ruptured. And this one is again gone more anteriorly. So there is incontinuity and irregularity of the spine. So it's multi-level disruption. And this one is impinging on the articular cartilage of the superior end plate and vacuum phenomena causing degeneration. So you need to describe this impinging, loss in disc height, probably displacement, and the whole cord is moved anteriorly. So the other thing is whether you need to look at the posterior processes, whether there is fracture. It doesn't look like there is a fracture here, but there may be a fracture there which is causing displacement of the vertebra anteriorly. Again, this is L5 over S1, so antrolisthesis of L5 over S1. So looking at this, so there is, if you just draw a line there, so there is movement here, so there is lateral displacement. You may not be able to see it on the sagittal, the only best view it will be. So that's why it's important, you need to look spine in all 3. So talking about the fractures, so I said you need to divide this into 3. So this is compression fracture of superior part of the vertebral body, superior end plate compression fracture. The inferior part is maintained, so it's not complete collapse. So you just need to see and then look at the posterior. This is very important. So whether there is any displacement, anterior displacement or posterior displacement. Anterior displacement I wouldn't be worried about. The posterior displacement, it is the most significant. So if it is anterior fracture, then it's a stable fracture. Middle is still stable because the most of the spine is supported by the posterior. And all the sensitive tissues are in the cord. So anything which displaces into the cord will cause either stenosis, paralysis, or radiculopathy depending on the compression. So this is the fracture classification, so superior end plate, inferior end plate, maintain vertebral height. You don't need to go into all that detail as long as you remember to say superior end plate compression fracture, complete compression fracture, or anterior compression fracture. So this is probably what you would come out. So this is the posterior, basically is completely maintained, anterior compression still stable. You don't need to do anything, but it depends whether this is acute or this is chronic. Again, if you're looking at the posterior part, this is the middle part. So this is the three parts of the vertebral body: anterior, middle, and posterior. If it is non-displaced, so you're not worried about, but still they are unstable, they need to do something about it because it can at any time can displace and cause severe neurological damage. So this is a combination. You've got multi-level disc, intervertebral disc changes with fracture. So it's a complete compression fracture, probably involving the anterior part, middle part, and maybe the posterior, but still you can see the posterior part still maintained. There is a bulge there. This could be a fragment which is moved from here and pushed posteriorly. You can't comment on this because there may be a compression. That's the cord coming. So this is probably indenting the dura, but you can't comment on this. So there's loss of incongruity here. So either there is a fracture which is causing displacement, so you need to do an MR, urgent MR on this, and then probably take the management further. So this is a nice clean representation of what I was saying. You've got a fracture, so it's involving the middle, avulsion fracture, so this patient may have had the extension injury, avulsed the anterior part here, and then cause compression of the posterior part, and you've got a bony fragment which is almost completely occluding the spinal canal. So this is an emergency. So you need to comment on this if you see it, and they need to intervene and stabilize the patient, otherwise the patient may become completely paralyzed. These are just the nutrient vessels crossing through. So that's the nutrient foramina. So you've got nutrient vessels, and you won't be worried about this because you see it here, 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 and it all depends. Sometimes if you are using low dose, you'll see more artifacts. So you need to be aware what is normal, what is abnormal. If I see lucency here, that's the pedicle. I'll be more worried. Again, yes, that's what I said. This is an extension injury most likely because this has avulsed through, and then if you do like this, the spine, so the pressure is on the posterior, so there's posterior compression fracture, and then the anterior lip has come out. Then again, you are liable to look at the rest of the anatomy and see if there is a quick review, and then if there is any obvious positive finding which may impede on the management, you need to mention that. How would you describe this? Any volunteers? I've told you everything, so sorry? Yes, but you won't need to add one more thing to that. Yeah, it's a fracture, and it's most likely a stable fracture, middle part. But you need to add one more thing to tell the clinician. Sorry? It's a pathological fracture because there are multiple metastases, and this bone is abnormal, and this is metastatic, and it has fractured. Like the long bones, when you talk about femur, you need to mention there is a metastasis at the intercondylar or in the trochanteric or in the neck, and potentially it can go into a fracture. Or if it is a fracture, then you need to see whether there is any, because the management changes completely. So they either give radiotherapy and fix it. So you need to tell them this is a pathological fracture, and there are multiple metastases with degenerative changes, and this one is compression. So they need to either radiotherapy this, otherwise it's not going to heal. So yes, so yes, these are metastatic lesions. So how will you describe this? Yes. And what else? The disc, you see this? Yeah, there is calcification within the disc. So this, basically, this gives you the diagnosis. This is L-captonuria. So there is calcification within the disc. This is pathognomic of L-captonuria. So you've got destruction with intervertebral disc calcification, and that's diagnostic. So again, multi-level disc changes are changes in the end plates, reduction in the disc height. With the moment you put calcification within the disc, the clinician knows that this is. So how would you describe this? You can say there is a defect here with the low density. So what is it? Yes, this is typical. So you see this, and you see this, and you basically, this probably is going to evolve into Schwann's node. So you've got different phase. And this, I think Gopi showed you, a very nice one. I've got it from his slide. So you've got, why is it not met? Yeah. Some calcification there. And then on sagittal, always look at the sagittal. So you see something creeping through into the cavity. This is geographic. So this is basically, this is a typical site. So you can just, sometimes this one will become a shallow here, and you will say, maybe I might have it, the example. So you can have variables. So this is very advanced. It's gone through. So you may have slight dimpling here, and you will see it when you report spines. So again, you will look at this. This is normal. This is relatively normal. So there is slightly reduction in the height, yeah? So probably there is compression there, maintaining the posterior part. The alignment is maintained. So it's only Schwann's node. So, and this is again, and this may show uptake. So we talked about this bulge. So it bulges posteriorly into the spinal canal and causes compression. So this may be disruption here, and laterally it can compress. So this is best investigated on MR. So MR, look at the spine here. This is the posterior longitudinal ligament, anterior longitudinal ligament. You just follow it. It's simple. It's just if you know what you're looking at. This is the cord. You see white bit. There is compression of this. So there is disc herniation causing compression, and this patient would have multi-level disc. Again, the same. So you've got facetal arthropathy there and discs, so a combination of both, from both side compression is causing spinal canal narrowing. Yes, so basically this is what I'm saying. So you look at the end plates, you see the disc height relative to this, and there is a protrusion. So the whole thing is protruded. So there is terminology. There is a bulge, just a bulge. You see the whole thing as bulging out, and then something when you push something and the whole thing goes posterior. So it's protrusion. So the whole thing is pushed back and it's compressing. So this is protrusion. So we talked about lumbarization, and this is basically what Gopi has already talked about: 2% population and presence of 6 rib-free lumbar type vertebra. This is, I think, sacralization is very important, because most of the spine I have done, you don't find anything, but then you see these fusion. The lumbar vertebra fuses with the iliac crest and the L of the sacrum. There is a ligament, the sacro-lumbar ligament, which goes, it becomes calcified, and this basically becomes a solid. So again, once you have got these ligaments and this fusion, then when you talk about fusion, you need to look at it whether this is complete fusion, partial fusion, or incomplete. Whether there is fibrous, whether there is uptake, and then you need to tell them that there you see uptake on spect CT, and that could be the cause of pain. Sometimes you ignore. Initially I used to ignore this, but then I started reporting this. And if you see, it can be bilateral, unilateral, and you need to go through all the way and see whether there is completely fused or there is some lucencies, which reflects non-fusion or incomplete fusion. Some clinical cases, I think Gopi has already showed you all these. So here there may be a Schwann's node developing, but here probably. So this is how you can see sometime. The rest of the disc is fine. So I think after this you should be able to report spines. So tracer uptake, so you, yes, the thing is, it's relative. You look at the normal one, then you see some, so the vertebra is fine, then you come up here, you look at this one, so you've got always something to compare with. If you are not sure, go up and down and then look at it, what is normal. So you see there is no uptake here, so that's the rib coming and it's articulating with the vertebra, so is costovertebral joint. This one, it looks hypertrophied, it's slightly moved, subluxed, and is showing sclerosis at the margin, so showing uptake. So there is joint arthropathy. And then you've got anterior osteophytosis, and on this side, on CT you may ignore it, you may say, oh, probably it's normal, but you see uptake, so that could be the cause of the pain. So you mention it. Again here, anterior lipping, osteophytosis, anterior osteophytosis. So now, if you're looking at this, what else do you see? Can you see it? So you see the anterior osteophytosis, and then I told you follow the contours, posterior column, anterior column, you come down here, and then that's the sacrum, and then you see this articulation, so antral listhesis of L5 over S1, and this is moderate. So you see this almost 50%, and this is significant. Then when you see this, then you think about whether this is pars defect or not, then you go back and look at the lamina and the pars, whether there is any defect or not. So again, here you see end plate sclerosis, reduction, probably Schwann's node developing there, degeneration, and then you see uptake and uptake posteriorly. So this is end plate degenerative changes. So this is commonly you see probably the most of the my cases, they will reflect how important it is. They on CT you will never tell them, you will not be able to tell them which one is active and which one needs intervention, because all of them look similar, but if they are hot, then that means that is active and possible the cause of the pain. Again, fascicular arthropathy is very common, and when you start doing spect CT, you'll be amazed when you start reporting. Now, this is important. Now, you look at the spine and then you look at this uptake. Normally, we just used to ignore it, say it's arthropathy and then ignore it. So this could be just spinous process, and this could be just because of arthropathy there. So bilateral pass, so you see what I was saying, the defect is most of the time like this rather than facetal joint, and it shows uptake. So this means there's still osteoblastic activity going on, and that could be the cause of pain. Always look at the axial and look at the sagittal. Sagittal will give you the diagnosis. So you've got fascicular arthropathy, arthropathic changes, vacuum phenomena, and then you've got uptake in the arthropathy here at the lateral vertebra, but the facets are normal, no uptake. So basically, if the patient has been referred to you, the patient has got back pain, can you identify the site? So you look at it, you say, oh, it's only this, but the facets are abnormal, but they are not showing any avidity. So we can't tell you what the cause of the pain is. So that's a compression fracture. The posterior element still preserved, so anterior and middle part of the vertebra, and it's showing uptake, and probably it's acute fracture. So his bone scan just basically tells you, and then there is asymmetry there, so maybe that's arthropathy, you can look at it. So there's some degenerative changes in the lumbosacral region. Again, this one showing uptake, collapse, and the fascicular arthropathy as well. So you can look at this, and if you look at it clearly, because there was so much of activity there, I couldn't appreciate. So this is between the disc, and that's probably the cause of pain. So I've already shown you this. So anterior osteophytosis and possible fascicular arthropathy. So you need to comment on that, because they don't want to treat this, but they need to treat this. So malignancy with metastases. So this is what I was saying, this is a prosthesis there. So if you see uptake there, so you need to mention it in this region, and you need to tell them how extensive it is, and they need to intervene before the patient develops pathological fracture. So they can radiate and put a prosthesis in before the fracture happens. So that's fibrous dysplasia. It could be giant cell tumor, but most commonly is fibrous dysplasia. So again, sclerotic, multi-level here, sclerotic, and uptake there. So it's prostate patient, so L2 solitary mets. Again, this was shown by Gopi. So pain in the navel cleft, and patient may have had slipped or fallen down, and you see focal uptake at the tip, and this keeping with coccygeal fracture. So this is what I'm saying. More and more when you start doing the PET, I've started seeing it. I didn't know that before, but now I start reporting it, because if you do a bone scan, if you do a FDG, and you see this focal uptake, or best rep you can see in a number of spinous processes, and you can see incontinuity. So this is benign pathology, and this is because of the uptake in the interspinous ligament, and it can be because of the supraspinous ligament as well, or together with the inter and supraspinous ligament. So I told you, if you're looking at a joint, if the two sides of the joints are involved and two sides of the joint are destroyed, then and you've got some ancillary findings with collateral damage and swelling, edema, so you think of infection. And if you are looking at an infection and then you think whether there is a TB element, then you'll have a large soft tissue adjacent to the destructive changes, and that's in keeping with Pott's fracture. And you see uptake with destruction of the joint, adjacent joints. If you are reporting on this, I would have reported this on this as bilateral fascicular arthropathy, because the pattern looks like that. But then you look at the history, the patient will be septic, pain, and the bloods are abnormal with some cultures, and then you do a spect. Otherwise, you'll just basically disregard and then say fascicular arthropathy with some SI joint changes, some shoulder joint changes, and then you just let it go. Thank you.